For me, I wasn't running from the traditional healthcare system. I was running to DPC because I believe in it, right? I did it before. I knew how it worked. For me, that was the right way of practicing medicine. For people who are just burnt out from the traditional system and they want to run away, it might not be the right fit because you got to go back to directionality question. Am I leaving because I don't like it, or am I leaving because I love something else more?
Dr. Kainkaryam is not your typical physician. He's an internist, pediatrician, and a TEDx speaker, but also entrepreneur, author, and devoted husband and father, and yes, even a passionate baker. After years of navigating the traditional healthcare system, Dr. K decided to rethink what the patient experienced really from the ground up, and that's what led to him create the 4 elements direct primary care and wellness space. It's really a bold way of reimagining what healthcare could be when it's built on trust, honesty, feedback, and a little bit of fun. So welcome to the MedStory podcast, where we share stories of healthcare entrepreneurs who are building a business and a brand outside of the traditional medical model. I'm your host, Spencer Locke. And if you're interested in something like this, make sure to hit subscribe and let's dive into it. Welcome, Dr. K.
Awesome. Thanks for having me, Spencer.
I want to dive right into this because I know that there are a lot of doctors who may be considering the DPC or concierge model. Let's start with the beginning. Help me explain to me the difference between DPC and concierge.
I think, within the DPC community, right, there's even disagreements on what words to use and what words not to use. And I think, concierge medicine historically was for the wealthy, and they typically charged you a really high retainer fee along with billing insurance. So it really was for those folks who wanted these executive physicals and, sort of the top of the top to be able to access your doctor anytime, all the time. So it really was catered toward a niche population. I think DPC is much broader in its breadth. And I think some DPC docs will use the term concierge in the fact of its concierge level service, but not from the same financial model, right? So the DPC financial model is one where we charge a flat monthly membership. We're not billing any third-party payer, and the memberships are a lot more affordable for the average person. So it's really catered for the large mass of people. And yes, you may have additional services that may be included in a concierge practice, but something that could be more a la carte style. So really going back to that old school doctor-patient, take out the third-party payer, take out all these other people who come in between, and reharness that relationship. I think at the core, that's where DPC is.
Okay. So you said it's a lower monthly membership, and I was looking at your prices on your website, and they seem very reasonable, but there's no way that you could offer full comprehensive care just by them paying for that membership, right? So how does that work? I mean, you would tell me, because if you're not billing insurance, like for example, how do they get access to their medications, or if they need a surgery, something like that?
Yeah. So remember, right? So what we're doing is direct primary care, right? So everything that we do is in that scope of primary care. So for example, right? So that membership covers pretty much my brain time when it comes to primary care. So anything that's additional, like ins or labs, that's also additional in the traditional world as well. It's additional in my world. Here's the difference. The difference is I will work with my patients on trying to find cheaper options for them so that they keep more money in their pocket, as opposed to me taking that money for my profits. So the incentives are different. So for example, some of the lab tests, my own rates are cheaper if the patient were to pay it than what they would have paid even with insurance. And that's sort of the whole mystery to this, right? Is that medications are cheaper sometimes even if you don't use insurance. And so anyone who's ever used like a good RX knows this. They just haven't thought of it, right? So good RX is basically a discount coupon. You say, oh, with my insurance, it's $150. Use your good RX coupon. And all of a sudden that came down to like $30 and you directly paid for it. It didn't get billed to your insurance. So most consumers have done it to some capacity, but didn't really take that step back to say, oh yeah, I chose to do it that way because it was cheaper than my insurance. That logic applies across the board in healthcare. CAT scans, x-rays, MRIs, medications, labs, you name it. So I think one of the things that we do is saying, okay, we cover our brain time, but if you need other services, let's help you try to find those same services that don't compromise quality, but reduce the cost.
Okay, that's interesting. And so when you do say if they need a lab test, will you then show a comparison maybe of what it would be to go through you compared to maybe their insurance to help them make an informed decision? Or how does that process work?
Yeah. So we have a very transparent price list. So all of our patients will get, hey, if you want to do anything through the practice at our rates, here's what we charge you. Straightforward. And so they can look at that. They can call their insurance and say, hey, here's my, how much would I pay for something like this? The problem with the insurance world is that they don't tell you until they've done it afterwards, right? So there's supposed to be all this price transparency, but it doesn't always happen. So what we try to do is guide our patients when we know that our prices are likely going to be cheaper, but also get a sense of their health plans. So if someone has a really low deductible, we say, if you're going to meet your deductible, then just bill everything through the insurance. If you've got a really high deductible and historically you've never met it, then your likelihood of meeting it is low. So save money when you can and don't bill it through your insurance. And so I think number one is giving them our prices. Number two, informing them how to ask the insurance company for their prices. But then number three, helping them assess what benefit they're likely to use and how much for the year to decide how they want to pay for it.
Wow, that's actually really cool. So when you are maybe setting it up where you offer them something like a lab test or a medication, what is that process? Do you have a third party vendor that you work with specifically within testing and medication?
Yeah, so there's a lot of rules and regulations around it, right? And so this is where, as a physician, you have to really understand your state statutes. And so, for where I am, I can dispense medication to patients under my physician license as long as I follow all the pharmacy guidance, right? I label it the same way, I give them their warning sheets, I make them sign. So I follow all those rules, but I don't need a pharmacy license. In some states, you need a pharmacy license. In other states, physicians can't dispense, period. So a lot of this medicine is so state specific. Even for labs, certain states, you can charge patients for it. In other states, they are required to bill the patient directly. So I think first step for anyone is you've got to begin to explore the legal landscape in your state because that's ultimately going to determine what you can and cannot do. The next piece is developing all these relationships, right? So as I started my practice, because I had done other things before and I had managed the medical operations for a 14 site community health center, I had all these contacts. And so I knew who to ask for. Hey, I want to set this up. I know you guys give good rates because I signed those documents in my other capacity. So help me get those rates, right? And so I think so much of this, as with any business, is who do you know? What are the relationships you have? And how do you sort of partner with those people to be able to create something new?
So from a financial model of the DPC model, I'm almost thinking of you like almost like the Costco style membership because Costco makes most of their money off their memberships and then they give you access to so many things where their margins are pretty thin. Now, I assume that you still should, and you should for the time that it takes to do all these, you should be making some money doing these lab tests and dispensing medications as well. Is that right?
I think our margins are very minimal on those. They're really just to cover our costs. So like shipping, admin time, stocking, just kind of, but it's pretty minimal, right? So it's a very, our goal for these other services is to give it to patients as close to our cost as possible because that is the value add to the membership, right? So that price differential, if you are not a member of the practice, you do not get access to. So someone whose family member needs a med or whatever, hey doc, like, can I get my 3 months of cholesterol medication for like your $5 or $4? They don't have access to it. You have to be a member of the practice to get access. So that's where the value is. So these kind of like that Costco model is the membership gives them access to all these different things. Yes, that do cost more, but it's going to cost substantially less because of the membership. Now, some patients, the price difference of their medication itself covers half their membership for the month. So it's kind of interesting when you begin to do the math.
Now, I'm thinking about this from a business standpoint because when I hear you say that, and then you're offering all these additional services and doing all these things, and only coming close to breaking even, it sounds like more work for you. And I could see someone that's trying to get away from all of the overhead and additional work in traditional medicine, but are they just coming into a model that's going to create more work for them in other ways?
So I will tell you, I think most DPC docs will agree that we don't work any less, right? I think unless you choose to, right? So you don't have to offer all these things. But when you're offering a membership that someone in their mind has to pay for something beyond what they think their insurance should cover, what value are you going to show them, right? And so I think for us, a lot of this was about the value of our membership. And so it wasn't about having that as a profit center, but it was really more having that as a value add for the core of where we make our money, which is the membership. And so that may mean over time that you have to increase your membership rate because you're like, hey, I'm spending all this time on this. I have to account for it somewhere. So your base membership rate may go up, but we try not to have those other be profit centers. So it just depends on how you want to design it. But I think also, to back to the initial piece, do I work any less? No. I probably work more, but I'm not working for a corporation that's telling me what to do. I'm choosing what to do, and I'm working for my patients for whom what I'm doing adds value to them.
Hmm. I love that. This is incredible. You are just trying to create as valuable of a resource as possible. And if the value is undeniable, then people can't help but want to be part of that community. And I think that that's really, really amazing. Now, with this, when you do this kind of model, tell me the breakdown between a standard primary care doctor. How many patients do they typically have on their I can't remember what the word is, but their workload compared to maybe a DPC doc?
So I think, so in the traditional primary care model, you're talking a panel size of 2,500 to 3,000 patients on the low end, right, for a full time doc. You're talking about seeing 22 to 30 patients a day. I remember when I first came out of residency, the rule was our medical assistants had to fill our schedules with 2.2 patients an hour. That was a minimum threshold. If and so for that, they had to overbook, they had to double book. You threw in anyone who needed anything in that day because you needed the quantity. In our world, I would say most direct primary care doctors keep panel sizes anywhere from to 500. So you're talking like a quarter, and actually probably even an eighth of what you'd be seeing in a different world. Now, there's more touch points. They're texting you, they're messaging you. So it's not like you're twiddling your thumbs. The difference is you're more involved in their journey as opposed to let me see you now. Hopefully, you'll get an appointment in 3 months. Hopefully, I'm not out of the office sick that day. Hopefully, it's with me and not with another member of the team. And hopefully, you're alive by then, right? And so it's kind of, it's kind of a joke, but not really. But I think that's the truth of that. The real system is when they leave that door, you don't know if you're going to see them again. And oftentimes, a doctor doesn't know that the patient's struggling to get in to see them because a call is going to some random call center who's disconnected from the office, and you just never hear back. And so I think the hard part is that physicians are victims of the system too, right? And so they don't have control over their schedules. They can't say, I only want to see this many patients because your salary has to pay your MA, the biller, the coder, all the overhead that needs to cover you being in those shoes. Whereas for us, we get to choose.
That makes a lot of sense. So for someone that does this, say if a patient transitions over to seeing someone like you, is there an option for them to, or for you to provide maybe like a super bill that they could apply towards their deductible? Or is that not an option typically?
So I think it gets cloudy because, some people try, it's not always successful. I think one of the things for those of us who do what we do is because we don't want to quantify every piece of work that we do. So every conversation with a patient, I don't want to assign a CPT code. I don't want to. So I think part of us is we want to get away from that billing and coding world, right? Because to me, that's administrative time spent that has zero value to the clinical work and the relationship to the patient. And so those of us who are in that world have to make the decision of saying, am I going to even dedicate any time to this? And what is the cost of doing it? And then you get the back and forth with, oh, the insurance didn't like this bill. Can you send this back? And they want more codes and blah, blah, blah. And then next thing you do, you find yourself sucked into the very world that you've tried to go away from.
Oh, that's a great point. Okay. And you're just setting your boundaries. You're saying, you know what? I got away from this for a reason, so I'm not going to dive back into that. Because I have heard of other DPC providers doing that. And
I
so,
think it depends on
oh,
how confident you are in terms of recruitment, right? If you can say, these are my boundaries and there's a market for your boundaries, then you're fine, right? But if there's not a market, you might have to flex those boundaries for the survival of your practice.
that makes sense. So what are some of the biggest challenges that you've had starting and growing your specific practice?
So I think where we live is a very insurance centric state, right? I mean, we're like the insurance capital of the country. So I think for people to realize there's a world outside of the insurance world, I have a choice, that itself is a very grassroots revolution. There's a lot of practices that attempted direct primary care and have then converted back to having a traditional model. And I think as a physician, you have to enjoy being a business owner. If you're not a business owner, you might want to be employed in a DPC practice, right? That's a safe bet because you can practice clinically without having to go out there and I don't know, do your TikTok dances and your Instagram reels and put all that social media because you've got to market your brand and yourself. The first year I started my practice, people were like, you've got to put videos out there. I'm like, who wants to see me? Right. And part of it is because in my mind, I was so used to thinking of corporate marketing. But then you realize your patients want to know you. They want to come for you. Who is the doctor? What is their life like? Do they practice what they're telling me to do? So you have to find yourself to say, do I feel comfortable marketing myself, right? They're going to know about me, they're going to know about my family, they're going to know where I live. It's that old school community doctor that, you run into the grocery store. If you're the type of person to be like, I'm going to run away from my patient, yeah, this is not for you. So I think there's an element of, you've got to know who you are. So I think that's number one. For me, it took a little bit in terms of the marketing, but I love talking to people, right? I can go on and on. So that wasn't the hard part. The hard part was, and it wasn't even starting a practice because, 10 years ago through a healthcare startup, I got to start a direct primary care practice for an employer based model. So I knew how to do that. I knew how to run a practice. What was different was the money. And my wife had a few rules, right? I can't take money from the family. I may not contribute, but I can't reduce the quality of life. And I couldn't take a loan. So I had to figure out how I was going to work all these additional jobs to fund my practice and try to contribute to the household. So we had internal boundaries, and that can be challenging. And you've got to figure out how to be creative with that. So I think that's probably one of the biggest challenges. And the second is for the first 2 years, I was a one man show. I had gone from a previous role where I was a C suite executive, I was one level below the CEO, and I had 8 directors. So I was delegate, 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 hold accountable, hold accountable. Whereas now I had to go back to I'm mopping the floors, I'm cleaning the toilet, I'm writing my protocols, I'm marketing, I'm taking care of patients, I'm following up, I'm booking appointments. So you have to like to want to do all those things. If you're going to say, I want to show up, my patients be there and go home, this is not for you.
Wow. And so were you working part-time as you were building the business?
Absolutely. So I was working different per diem options, part time, consulting, just kind of, it's a little tricky with DPCs because if you're going to opt out of Medicare and Medicaid, then you're going to have to work at a place where they're okay having an opted out physician because then I can't have them part of my DPC panel. So we had to make some key decisions early on, but then obviously like a few months after starting my practice, the whole world shut down because of the pandemic. So that was interesting. So I think it was a unique journey. Let's put it that way.
It sounds like it. How did you handle that? How did you handle the start of the pandemic with aligning with the start of your business?
So I think as a patient, if they had the option of, oh, my doctor texts me already, great. I don't have to get exposed. I could do a video call with my doctor and there's no additional cost. I don't have to get exposed. They're a low volume practice, so I don't have a waiting room with a bunch of other people. Great. I don't have to get exposed. They can see me in the parking lot. They can do house calls, right? So it showed the flexibility of what we could do in such a positive way that the traditional medical system had to begin catching up, right? Telemedicine has always been a thing in DPC, right? Like 10 years ago, I was texting my patients and doing video chats with them because I didn't have to code to an insurance. So when the pandemic started, patients were like, this is great. Like, it's less risk for them and it's more convenient.
Mm. It almost accelerated it at a point for you. It's like, okay, this is go time and it's an opportunity for you to fill those gaps during that time.
I mean, it was great marketing material. Let's put it that way. You want to avoid getting COVID. We only see like one patient an hour, so come on in, right? So it's
I love that. So, at what point did you decide to move from doing the per diem gigs to being like, you know what? I'm putting my full time energy into this.
so I still do them, even though I do full time in my practice, because I think I enjoy some of the per diem work that I do, and so I think it's been one of those interesting things where do it out of choice, out of sort of enjoying the work, so I kind of work more than one full-time job, right? I've got a few different things I'm doing in addition to my practice. So I think at the end of the day, the difference is everything I do, I get to do because of choice, right? I don't have to do anything. I could just do only DPC and do whatever I want with my other time, right? But I'm choosing to still allocate time for certain things because I want to. And I think that power, going back to you as a physician in DPC, it's so hard to explain to anyone else because physicians are used to having power taken away. Right? As a resident, you've got your attending, and as an attending, you've got your employer, and then some administrator slapping you on the hand for not having billed this much. And so over time, you just succumb to all these pressures and you forget the control that you have. And I think that's what DPC brings back.
Man, when I hear you talk about this, I feel a range of emotions. I feel excitement because it's cool to see our doctors taking back control of medicine. But at the same time, it actually kind of scares me. And I want to tell you why. Because as I see this massive shift of all of these doctors that are saying, you know what, I have lost control and I am burning out of the current medical model. And I want to transition to something beyond that. It makes me a little bit worried because then what happens as more doctors transition to this model? What happens to all those other patients? Like, what does our future look like?
I think the answer is the system has to change, right? So I think part of this is, you know, so that's always an argument against DPC, right? When you say, oh, what's going to happen to those other 1,500 patients or 2,000 patients that you're not taking care of? The answer is, yeah, number one, it's going to hurt a little bit for them, but they have a choice, right? They could join your practice if they want to. And I think for a lot of people, it's not that, it's interesting. I have patients who are uninsured. I have patients who are on Medicaid, Medicare, who are saying, this is a worthy investment. I'm going to pay for it. So, number one, it depends on how they reallocate their priorities. Number two, you have doctors who are leaving medicine, period, right? And so, primary care, people are leaving left and right. DPC has a potential opportunity to keep them the system as opposed to leaving healthcare completely and going to work for pharma or insurance. There's was an interesting article recently about the percentage of people who have studied medicine and are just not practicing medicine anymore. Those numbers are going to go up. So to me, DPC is a retention strategy in primary care because let's face it, like very few people want to go into primary care. It is extremely underappreciated. You're exhausted, you're burnt out, you've got all these notes to write at the end of the day and it's a thankless job because oftentimes your patients are grumpy at you because you're late, they got in late, they're upset with the staff and they take it out on the doctor. So at some point, when do you say I choose no longer to be the victim, but I still choose go with my calling of medicine. And so what I tell my patients is this is the way I practice. I am not here to convince you that my practice is right for you, but I am entitled to practice medicine in the way I believe it should be practiced. If it's a good fit for you, then let's talk. If it's not, that's also okay. Right. And so, and vice versa for them, they need to interview me. No patient's allowed to join the practice without interviewing me. And at that point, I will answer whatever question they want to. Why am I doing what I'm doing? I had one patient ask me, do I believe in God? I had other patients ask me, do I take pharma reps in the office? So for them, they need to make sure that I'm someone that they want to trust. And if they can't trust me, I'm not the right doctor for them.
Oh, wow. It's that energy that you're putting out there. It's almost the with or without you energy to saying, you know what, I'm going to stand in what I believe in. And you presenting it in that way makes me trust you immediately because you're saying, you know what, this guy believes it. He's going to stick to his guns. And that's the kind of doctor I would want to work with. So I have so much respect for that. And I think that oftentimes they may say, oh no, I can do this for you, or I can do this for you, and be really pleasing on them. But then they get pulled in so many different directions that they end up back at square zero. So I totally have respect for that.
Yeah, you got to know your boundaries, right? And so there's a lot of people who are like, "Doc, can I come in for a one-time visit?" It's a hard no. Like,
Mm.
I don't care how much you're going to pay me. Like a one-time annual physical is a hard no. So it's you're either in for the model or you're not, because I'm not about to invest my time if you're here just for a one-time thing.
So with that being said, if a primary care doctor decides to go to this kind of model, is there financial upside to it? Will they be making about the same, or what does that look like?
So I think most doctors will at least, you'll break even to what you made before. It'll take you a while, right? It's gonna be years potentially where you don't pay yourself, and that's just gonna be part of starting any business, right? I think this is where the doctor has to take off their doctor hat, go to their I'm a business owner hat. One option. Number two, you work as an employee where there's a little bit more safety and guarantee. Number three, you take an investor, but now you've given control of your business, your blood and sweat to an investor, which I refuse to do. So I've never had anyone investing in the practice. And so these are your options, right? At the end, the way you do it is you say, how much do I want to make? Great. How many patients do I want to take care of? Cool. And how much do I need to charge them to be able to make what I want to make? Right. And so it's backwards math. And then you say, now, is there a market for what I'm doing and what I'm offering? If there isn't, then you readjust that. And then you say, what else can I do that will supplement my income that I still want to do and I believe in that will then offset some of that financial requirement that I have?
Okay, that makes sense. So let's say now they've decided, you know what, I'm willing to do that. I'm willing to step into it. And then they can build up to the point where they get to that 300 to 500 workload. Now they have the option is do they continue to stay small or do they grow from there? For you personally, what's your goal within the next 1 to 3 years?
So I think for me in total, I want, four sites, sort of a main site, a few satellite sites, a handful of doctors, not too many, enough so that you still know each other and you have that collaboration. If you're too big, you it becomes corporate again. So really kind of, my goal is always to have that small business, but to sort of iterate on the services that we offer and say, all right, how do we do this better? What else can we add? What else can we do? And it could be that for some of the other non-primary care services that we pull certain people in, but it's sort of I think for the vision for me has grown from primary care to primary care being the center of this healthcare continuum. And that's this Vitality Institute that we're building, right? So building is how do we center other services around wellness and prevention? And so that's where our massage therapy comes in, our acupuncture, our hypnosis, our cooking classes, our medical weight loss, our fit personal training. So it's really saying, what are things people are seeking on their own? How can I create this continuum for them where I'm the doctor and I still have an idea of everything that's happening so that they're not floundering by themselves and I can help them figure out some of the nuances of these other services. So that's kind of where our next vision is going to be of what we're doing.
That's super cool. And I think beyond that is how do I take that continuum and how do I turn that into a community where
Well,
it
and
starts operating
exactly.
itself?
So part of that, right, is in this new place is we're going to actually have a lot of community work. So we're going to have a community garden. You want to learn about herbs? Come on in. Bunch of our patients hang out, meet each other. We're going to be doing a lot more just drop in for coffee. It's funny because I recently had a patient who was traveling internationally for a procedure, traveling to a country that I had another patient from, and I got permission of both of them to introduce them to each other to help each other out. And I had another patient who I know drives professionally for work, another patient who needed a driver, and I said, maybe the two of you should connect. So what's been really interesting is that you become a connector, right? So as a doctor, I know which of my patients are struggling financially. Oh, you need a job? I happen to know someone in your field who's hiring. Let me make that connection. And so that has been really fun because you're almost a business networker among your patients as long as they're comfortable divulging that they're your patient to another person who's also comfortable divulging that they're your patient.
And honestly, that might be the most powerful thing that you're providing your patients, even more powerful than the medicine that you're giving them, right? Because
And I'll tell you
you,
this funny
go ahead,
story. I do want to share this one is
please.
to the point where one of my new team members, one of the patients was their parents were looking for a bride for them. And this team member happened to be from their same community. And I was like, "Do you know anyone?" And they're like, "Yeah." And I was like, "Great, here we go." And so to the extent of matchmaking has occurred in our practice. So that just to give you a sense of the fun we have.
Oh, that's so cool. You have to understand that you have done the work to get yourself here to provide yourself these opportunities. And these never would have been possible if you decided to just stay in the current model. Right. And so, what do you recommend? Because there are a lot of doctors that are still in it that want to figure out that way to break away with it, whether it's DPC, coaching, speaking, writing a book. Where could they start to start moving towards that direction?
So first of all, you've got to answer the question, what are you running from or what are you running to? So for me, I wasn't running from the traditional healthcare system. I was running to DPC because I believe in it, right? I did it before. I knew how it worked. For me, that was the right way of practicing medicine. For people who are just burnt out from the traditional system and what they're doing, they want to run away, and DPC is just one of those many options, it might not be the right fit, right? Because I think for something like this, you got to go back to that directionality question. Am I leaving because I don't like it, or am I leaving because I love something else more? And that I think is that first question. If someone's looking to say, I'm just burnt out of the traditional system, there are a ton of options. DPC is one of them, but it's not worth doing DPC unless you feel like you're at a point where you're running toward it and you're saying, this is my heart and soul and mind, and I believe in it. Then you do it because it's really hard. If it's the former, then maybe just join a DPC practice where you don't have to do all the work that comes with it. Maybe look at concierge practices where they will set you up with all the stuff and you just sort of franchise out that work. Find out what you enjoy. Do you want to be an author? Do you want to be a speaker? Like just kind of all the stuff that you said. You've got to find out what fills your cup. And it might not even be medicine, or it could be that doing this other stuff makes medicine a little bit more tolerable. And so that's the kind of nuance you have to figure out.
Yeah, that's incredible. I genuinely love the idea of what you're building, but here, like, I think that there's going to be so much value, and it sounds like there already is. So if they're a doctor or maybe even a patient wants to like kind of learn about what you offer, what is the best way to either reach you or someone in your community?
Yeah, so I think, they can always reach out to me on Instagram. It's easy enough to send me an Instagram message. Dr. V cares for everyone. K cares with a K, 4 with a number 4. And so, I'm happy to, people can always send me an email. There's a lot of people who are, I think one thing that's unique about DPC is that we are very supportive. There's a lot of us who are in national organizations and Facebook groups, and we're always sort of sharing best practices and ideas, right? When I started my practice, I visited a bunch of DPC practices. I got ideas from them. They helped me think through. They challenged some of my thoughts. So I think finding a DPC doc, visiting their practice, getting a sense of their real life, asking them the tough questions of, all right, how much do you really make? Is it worth it? You start there. And I think very few DPC docs will say no. Like even when I travel, I always visit a DPC practice when I travel and I say hi, introduce themselves. And I can't tell they will block their schedules to see you. And it's a community. And I think part of it is that we're in this movement together and there's just so much support. You just have to begin to ask the questions.
So if you were to say your cousin was in a different city and they said, you know what, I would like to access something like this, like a DPC, what would be the best way to search for that? And how can they determine whether or not it's truly valuable versus predatory?
So there's the DPC mapper. There's a bunch of other like, even just searching direct primary care, and there's some companies that are trying to create these resources, right? That being said, Some of them are paid resources, right? You don't ever get access to the practice, but if you click on their link, there's some type of fee that either the practice is paying or you're paying for that connection. So I think, start off by just searching for a direct primary care doctor in general, but then you got to really get to know them and their model because, so let's say a patient of mine moves, they move to another state that I'm not licensed in. I will search those practices for them. I will vet those physicians for them. I will tell them their practice style is the most like mine, or these guys is a little bit more different so that they know what they're getting into. And vice versa has happened, right? I've had patients move across the country where their doc reached out to me to ask if I was accepting patients, to ask if what my style was like. And to this day, I still reach out to them to be like, hey, can you send me this echo report from whenever, right? So the docs, I think that's sort of the unique piece is find any DPC doc. Most of the time they will help you or they're networked internally that they will query their community and get you names that would work for you.
How long have you been practicing medicine for?
Oh God, I finished med school in 2008.
2008. Okay.
Yeah, I finished.
That's it's really refreshing to see someone that's been in the field this long and still as passionate as you are. And
Thank
I
you.
wish it was more common, but it's almost like a breath of fresh air. So I'm really excited to kind of see where you take the practice from here. And like I said, I hope that we can continue this conversation because I would love to talk again 6 months, 12 months down the road and watch your evolution as this community continues to blossom. But yeah, I so appreciate you coming on the podcast. And I know that a lot of people that are listening to this are going to get a ton of value from all the wisdom that you just shared.
Awesome. Appreciate it. Always happy to share.
Thank you, Dr. K.